Hello everybody, my name is Shannon Linton. I am a nurse practitioner student at Creighton University. Some of you have seen me following around the hospitalist group over the past year, and some of you have also worked with me. So today we're going to be talking about sepsis. There's going to be some changes coming up in your protocol and the way that you approach being able to identify sepsis, especially on the nursing side. So this presentation is to kind of just give you an overview of the changes coming up and also just to review a few concepts regarding sepsis. So the main purpose of this presentation, like I said, is to become familiar with some changes that are going to be coming up, especially on the nursing side for the way that you approach sepsis. The biggest thing that's going to be happening is a new sepsis identification tool that's going to be added to your charting should a patient screen positive for sepsis. So I'm going to spend a little bit of time first just reviewing some definitions of sepsis just to kind of compare and contrast SIRS, sepsis, and septic shock, all the differences with it, so that you guys kind of have a refresher on the sepsis signs so that we can successfully identify and treat patients early. Then at the end, we'll spend some time just kind of going over a couple of case studies so that you guys can apply all of this information. Something that I do want to reinforce is that these changes really aren't going to be that bad. I've been a nurse for about 6 years, and I've been in your shoes multiple times when it comes to having to learn a new protocol or a new process, and I do know how overwhelming it can be. I know you guys definitely aren't strangers to a change, so I want to tell you that this new tool is going to be a pretty minor change to what you're already doing in your approach to sepsis. It's more of a tool to just kind of help you guys work through these patients that require a little more interventions if they're starting to show signs of an infection. So I don't want you to panic, just bear with me as I go through this, and hopefully things will make enough sense to help you get started with the process. Once this tool does start to get rolled out in the next month or so, there will also be super users who are trained to help you guys just to answer your questions and make the transition as smooth as possible. I think with time you guys will find that it really isn't that bad. It definitely won't be without speed bumps. Nothing is perfect the first time. The facility that I currently work at made this same process change a few years ago, which is one of the reasons that I'm helping Kearney Regional with these changes. It did take some time to get used to, but overall it turned out to be a pretty smooth transition. So just don't panic and just bear with us as we go through this. So what is sepsis? Sepsis is a clinical syndrome that has a physiologic, biologic, and biochemical abnormalities caused by a dysregulated inflammatory response to infection. Sepsis and the inflammatory response that ensues can lead to multiple organ dysfunction syndrome and death, which is why it's so important to become familiar with how to identify sepsis. Basically, in short, it's a life-threatening condition caused by a body's response to infection. So the body normally releases chemicals into the bloodstream to fight an infection, and sepsis occurs when the body's response to these chemicals become out of balance and trigger changes that can lead to damaging multiple organs and become pretty life-threatening. So just some facts about 1 in 3 patients who die in a hospital have sepsis. About 1.5 million people get sepsis each year in the US, and at least 250,000 Americans die from sepsis each year. So pretty big numbers, which again is why we are going through this. So why is this important? Like I said, anyone can get an infection, and almost any infection can lead to sepsis. So your patients really are counting on you to be able to identify the early signs of sepsis. The Centers for Medicare and Medicaid Services actually require us to document our efforts in identifying and treating sepsis. And if we miss part of these requirements, we don't get full reimbursement. So it's just really important for the hospital overall to be as diligent as possible to identify these patients and get them treated early. So this slide is just to kind of give you a general overview of the common sites of infection. The lungs are the most common, followed by the primary bloodstream. Next is the intra-abdominal cavity and the urinary tract. Skin and soft tissue can also definitely become infected, and then there's some other areas also, but just to kind of keep in the back of your mind some of the most common sites when you're treating your patient. So again, this is just another slide just as a general FYI for you guys. These are some of the most common pathogens that can cause sepsis. Obviously, you don't have to memorize any of this. This is more of the provider's responsibility. But mainly what I want you to take away from this is that this is why getting cultures are so important, and we'll talk more about this later. Because there are so many different pathogens that can cause sepsis. So this is just kind of a general FYI for you guys. So as far as the pathophysiology of sepsis itself, I'm actually not going to get into this only because that's not totally the purpose of this presentation. But I think most of you guys have hopefully gone over this in nursing school. So I've included a link here from Khan Academy that does a great job of going over the pathophysiology. This is a really great website. I use it a lot for school. They have some really great videos on all sorts of subjects. So if you're interested more in the pathophysiology behind sepsis, you can visit this link and learn it on your own time if you're curious. Okay, so next we're going to go over some definitions. The first is systemic inflammatory response syndrome. What I really want you guys to remember about this is that SIRS can be a normal thing. SIRS is a non-specific process that can be caused by ischemia, inflammation, trauma, infection, or several other insults combined. So just remember that SIRS is not always related to an infectious cause. As far as the definition of SIRS, it's when there are two or more of the following conditions. So a fever of greater than 101 or less than 96.8, a respiratory rate greater than 20, heart rate greater than 90, a white cell count either greater than 12 or less than 4, or bands greater than 10%. So two or more of those meet the criteria for SIRS, but once again, just know that SIRS, this response can be a normal response, or it can be a clue to something underlying that can be more serious. So next is the actual definition of sepsis. So sepsis is the SIRS criteria in addition to a proven or suspected microbial or infectious etiology, plus one or more signs of organ dysfunction. I'm not going to read all of the signs of organ dysfunction here. There's quite a few of them. I know you guys have probably seen this already, but these criteria are already listed in Meditech for you in your charting. So I listed them here exactly how they appear in Meditech. So don't feel like you have to memorize them. I think it's really important to become familiar with them, especially when you're assessing your patient and just getting used to recognizing the signs. So once again, sepsis is SIRS with a proven or suspected microbial etiology and a sign of organ dysfunction. So I threw this slide in because I thought it was a really interesting visualization on the differences between SIRS and sepsis. Again, I want you to note that sepsis isn't always from a bacterial cause. There can be other causes such as fungus, parasites, viruses, but on the other end of the diagram, and this was something that I was trying to reiterate earlier, is that there are other conditions that also show a SIRS response, but it doesn't necessarily mean that the patient is septic. However, it's still important to be cautious of these conditions, and the ones that I'm talking about are listed there: trauma, burns, and pancreatitis, because they can lead to sepsis later, mainly because of tissue necrosis, but once again, SIRS, it can be a normal response, and it doesn't always necessarily mean the patient is septic. So our last definition is septic shock, which is sepsis with hypotension. So a patient that has a systolic blood pressure of less than 90 or 40 millimeters of mercury less than the patient's normal baseline for their systolic blood pressure despite adequate fluid resuscitation. It can also, another sign is a lactic acid greater than 2 despite adequate fluid resuscitation, and again we'll go over this in a little bit, or if vasopressors are required to maintain a systolic blood pressure greater than 90 or a MAP greater than 65. And then another definition that I just threw in, refractory septic shock, is septic shock that lasts for 1 hour and does not respond to fluid or pressor administration. So who is at risk? Like I said earlier, anyone can get an infection, and almost any infection can lead to sepsis. There are certain patients that are at increased risk over others for developing sepsis, and these are, we see a lot of these people, people with chronic medical conditions such as diabetes, lung disease, cancer, kidney disease. It's especially at increased risk for patients 65 or older, or patients with a weakened immune system. So what are we doing with this information? So as I mentioned at the very beginning of this presentation, Kearney Regional is going to be implementing some documentation changes on the nursing side, mainly so we aren't missing the requirements outlined by CMS. The second reason is that sepsis interventions are extremely time sensitive. There are specific time frames and requirements that we need to make sure that we are meeting, that are both recommended as current evidence-based practice and by CMS. So next I'm going to introduce to you guys a new tool that is going to be used in addition to your current charting for sepsis in Meditech. And this is mainly a communication tool so that there isn't any confusion on what needs to be done and what has already been done by nursing and providers. And you'll see what I'm talking about in a second here. Okay, so this is currently what you guys are doing as far as sepsis screening and documentation. So what's going to be added is if you go through this sepsis screening and you make it to the bottom where you're having to notify the physician because the patient has screened positive for sepsis, the next thing you're going to do is you'll notice that there will be this little P at the top of the screen that I have highlighted in red. And if you click on that, it's going to print off a tool that is going to guide you through the next steps when the physician gives you orders, and also cues you to ask for orders that might be appropriate. Okay, so when the tool prints, this is what it looks like. I don't want you to be too overwhelmed by this. I realize that this looks overwhelming at first glance. In the next couple of slides here, I'm going to break it down for you to show you that a lot of this is already similar to what you're already doing. There's just a few things added, and mainly this is meant to be a communication tool between nursing to make sure that we are meeting our requirements. So just bear with me as I go through this a little bit. So first, what I want you guys to recognize on this tool is that these areas that are highlighted in yellow are exactly the same as the screening that you just filled out in Meditech. So what you see in yellow here, exact same verbiage as what you have on the screen here. So what is going to change is that once you have the initial screening filled out, these areas here that are highlighted in yellow are the next steps that you're going to take, possibly if you get orders from your physician for a patient with sepsis. I know this looks confusing, so what we're going to do is run through a few case studies, and I recommend, hopefully the tool has uploaded into MCN. So what I recommend is when I go through these case studies, print off the tool yourself and just kind of have it ready here and practice filling it out as I go through these case studies, and I will show you exactly what to fill out. So once again, don't panic. I know it looks overwhelming, but I think once we go through it with a couple of case studies, you'll see that it really isn't that bad. Okay, so the first case study we're going to go through is actually an ER case study. We're going to start with this because this is most likely where you're going to see this tool being used the most, because there's so much going on with a patient that comes in septic, and there's a lot of communication that is really important between the ER and the floor or the ICU. So an 88-year-old woman comes into the ED per ambulance at 1800 from an assisted living facility. By report, she has had chills and a productive cough for 3 days. In the past 24 hours, she has become weaker and does not want to get out of bed. Her daughter told the ED staff that she is saying things that don't make sense. So you get her hooked up, and at 1810, her vitals were temperature 102, heart rate 118, blood pressure 84/50, respiratory rate is 24. She was on 87% on room air upon arrival, and she is now satting 92 on 4 liters. The ER provider tells you to order a chest x-ray. It gets taken at 1820 and shows a right lower lobe infiltrate. Then at 1830, labs are drawn, and at 1915, because labs are super fast like that, you receive the results, and the white cell count was 17. Her creatinine is 1.8, and her lactic acid is 4.2. Blood cultures have also been ordered and drawn. So the ER is swamped as usual, and the provider tells you to give lactated ringers IV 30 mL per kg per the sepsis protocol. She did not receive any fluids by EMS. She is 95 kilograms. Antibiotics have also been ordered. So let's say that you're in the computer and you are charting on this patient, going through the sepsis screen, and obviously the patient screens positive for sepsis. So the next thing that you do that I showed you earlier is to click on that little P at the top of the sepsis screen, and that will cue a tool that prints off. So this is the lovely tool that prints off. So like I said, so first you start with filling out what you've already filled out in the computer, and the top part of this tool mimics exactly what is in the computer for that sepsis screen. So we'll start with column A here. You'll notice that the columns are labeled A, B, and C. So first we have a new suspected infection, and the patient came in, so this is where there's kind of some debate about when you suspect the infection. Technically, the patient came in at 1800, even though we have a documented infection at 1820. Really what they're looking for is when you first suspect it. So the time of suspected infection would be 1800, because that's when the patient came in, and that's, you can immediately see that the patient obviously has some infectious presentation going on from the fever and the chills, cough, all of that. So fill out the time there and your initials. So next is the SIRS criteria. So looking back at her vitals, the temperature was 102, so we'll check there. Respiratory rate was 24. The white cell count was 17, and the pulse was 118. So again, for SIRS criteria, the criteria are met when there's 2 or more, and obviously she met all 4 of them. So a lot of the times these things are met at different times, and the key is to take the latest time. So we know that we got the vitals right at 1810, and you don't have to write this down, but the white cell count was, you drew the labs at 1830. So technically, the time met for at least 2 of the above for as far as the time met for at least 2 of the above criteria would be 1810 because you met 2 or more even before you got the labs. So we're going to fill out 1810 there. And then we'll move on to the last column with the organ dysfunction criteria. So we know that the patient came in and they were confused, as noted by the daughter. Labs were drawn and the lactic acid was 4.2. And then the patient was also hypotensive. So let's see right here. And then the patient also was on Romare initially and had some increased oxygen requirements. So we'll check that there. So again here, when you're determining the time, it's when the first organ criteria function was present. So technically we know that the earliest organ dysfunction criteria was the change in mental status, which was right when she came in. So that would be at 1800. All right, so we've got everything copied down from the computer and we've determined the times that all of this stuff happened. So the next step, obviously you already notified the physician, so you're going to fill that out right there too. So the next part is filling out this here. So one thing that is key is to, and this is more important on the floor than in the ER, but you want to make sure that when you're filling out these times, it's technically that if the patient screens positive for sepsis, B and C have occurred within 6 hours of each other. So obviously all of this was done in the ER, so we know that these things happened within 6 hours. So next is determining the start time of when the patient screened positive for sepsis. And so when we look at the times, we actually take the latest time because technically all 3 of these categories have to be met. So when you look at the times, the latest time is 1810. So that's what we're going to call our start time for sepsis when they screened positive. I'll just initial here. All right, so last is filling out this bottom part, and this is the part that's brand new to you guys. So, and this is why I wanted to run through this with you. So first we need to fill out our time frames for our 3-hour and our 6-hour events. So right here and right here. So what we're going to do is first calculate our 3-hour event. So we know that our start time was 1810. So you take 1810 plus the 3 hours, which would be 2110. And then the start time plus 6 hours, which would be after midnight at 0010. All right, so, and this section is especially where things are so important for documentation because we have such a short amount of time to get all of these things done. And again, these are evidence-based guidelines and also requirements by CMS that we get these things done within this specific time frame. So. All right, so filling out this bottom part, we know that blood cultures have already been drawn. We drew them with the labs, so we said that that was done at 1915. And then our lactic acid result was 4.2. Antibiotics were also ordered. The big thing with antibiotics is if you have an order for those and also an order for your blood cultures, you need to make sure that you're getting your blood cultures before you give your antibiotic. So just something important to remember. So we'll say, so the lactic acid result was at 1915. And we'll say we started our antibiotic at 1930 because, again, pharmacy is also rushing super fast. And then because our patient is hypotensive and the lactic acid was greater than 4, the ER physician is wanting to give the 30 mils per kg per the sepsis protocol. So I made an area down here so that you guys can calculate this and also as communication for the nurses on the floor when you pass off the patient. So We know that the patient is 95 kilograms, and so if we take that times 30 mils, that would equal 2850. So what this means is that, and this is the really important part, is that we have until 2110 to get these IV fluids in. So it's really important to document when the IV fluids were started and when they were finished. So just know that that's a big priority right away. Also, all right, so let's say that we got the order for our IV fluids. Probably it would happen right at 1930, like when we're giving our antibiotics. So we're starting our IV fluids, so started them at 1930. So next, we'll look at the rest of this case study here. So we're given the IV fluids, and we don't have a definitive evidence of response to the initial efforts with the IV fluids because the ER would like to kick this patient out and get him transferred to the floor immediately. So far you as the ER nurse have given 750 mils. You give report to the ICU and you transfer the patient. And again, this is where this communication tool is important so that there isn't any confusion of where we're at with these 3-hour and 6-hour events. So we'll go back up to finish the volume resuscitation here. So EMS, when the patient was en route, didn't give any fluids, so we don't have to worry about that. We'll just kind of X that out. So this is where you're going to have to do some math again. So the total infused by the ER, like I said, was 750. And then what the floor nurse is going to be asking you in report and looking for on this tool is how much is left. So we have 2100 left, which again, it is difficult to get this fluid slammed in an appropriate amount of time. Typically the ER tries to get all of the fluid in before transferring to the floor, but in the rare case that they need to transfer to the floor before the fluids are finished, that's where this tool comes in handy. So once again, we have until 2110 to get the fluids finished, so we'll say that we got them just in time at 2100, and then just make sure that you're initialing all of this as you go. Alright, so last part of the case study. Later, the patient has arrived to the ICU and has received the full amount of fluids. However, the patient's systolic blood pressure still remains less than 90, heart rate is 110, and the urine output is still less than 30 cc's an hour. So with this last part with these 6-hour events, one thing that we've worked on with lab, and this is where we've been actually falling out with CMS requirements, is repeating the lactic acid in time. So what we're actually able to do is lab, when they first get an order for lactic acid, they are automatically going to put in a recheck for the lactic acid within 4 hours. So that should be something that's done automatically, so you guys don't have to worry about that, but obviously make sure you're communicating with the lab to make sure that they are truly doing it. So let's say that the lactic acid was redrawn in 4 hours, so around right at, we'll do it like right at midnight. Alright, so we'll just kind of make this up, that the lactic acid redrawn was 1.8. Alright, so this last part, and this is another thing that tends to be kind of complicated when we're trying to meet requirements, is if the patient has received the 30 mils per kg and they're still hypotensive afterwards, current guidelines tell us that we need to start a pressor. A lot of the times a physician will just give more fluids, and obviously you can't help if you don't get the order. Just make sure that you documented that you asked for it. But it is important to try the best that you can to get an order for a pressor to be started within that 6 hours if the patient doesn't respond to that initial 30 mils per kg. So again, you have an until 0010 to do that, so we'll just cut it close again and say that we started it at 05, and then just make sure that you initial it. So obviously, like I mentioned earlier, this isn't going to be perfect the first time that we're trying this out. I realize this is a lot, so we'll have some more case studies for you later, but this is just to kind of get you started on what this tool will be like. And I'll also attach these case studies to the MCN module so that you guys can also kind of stare at it and work through it yourselves too. So that is our first case study. Alright, so this next case study, I wanted to give you an example of what a floor scenario would be like, so a patient that isn't coming from the ER. This one is going to be a much shorter case study. I apologize, that last one was kind of long, but I wanted you to see what it's like to have to fill out the entire tool. But there are going to be scenarios where you won't have to fill out the full thing. So for this patient, you're the nurse coming on to day shift and you're assigned a 78-year-old male admitted yesterday to the med-surg floor for IV antibiotics for a newly diagnosed UTI. Past medical history is listed. He has already been started on IV antibiotics at admission. While getting a report, you're told that the patient has started to spike a fever, a low-grade fever during the night with the max being 99.1. Following a report, you review the patient's CBC, which was drawn at 5:30 and revealed a white cell count of 13, which is actually decreased from 15 yesterday. At 7:30, you do the patient's first assessment. The wife is at the bedside and states that her husband appears confused. He was previously alert and oriented. So you take the patient's vitals, which are found to be a blood pressure of 100/76, heart rate 102, respiratory rate is 20, and the temperature is 101. So I can already tell you, filling out the sepsis screening in Meditech, that this patient is going to screen positive for sepsis. Oh, excuse me. So you're going to go to the top and print off the tool again by clicking on the little P. And so you get it printed off, and you've got your tool. Alright, so this patient is different because they already have a documented source of infection. So we're going to go ahead and fill out column A here and check this here. And technically the time of, this is going to be time of known infection, so this will just be with your assessment. So you're just going to end up writing your assessment time here for your morning assessment. So again, moving on to the SIRS criteria. So this patient essentially met all 4 criteria. So temperature was 101, respiratory rate was 20, white cell count was 13, and the pulse was 102. So once again, met all 4. On this one, again, SIRS is positive when you've met 2 or more of these criteria. So, but you have to take the latest time that the patient screened positive. So this one is a little bit different because you drew the labs before you took the vital signs. So the labs are done at 5:30 in the morning, but you did your vital signs at 7:30. So they technically don't screen positive until 7:30 because the labs were an isolated event and you need 2 criteria. So the time for this one would be 7:30. So moving on to the last section, new or unexplained change in mental status. The patient is more confused from baseline, so you will be checking it there, which again occurred during your assessment. So we'll be putting 7:30 down there. So because they screened positive, you're going to have to call your physician. And so let's say that they ordered a stat lactic acid and they're wanting some blood cultures drawn. So one thing that I do want you guys to notice on this is the column B and column C have to occur within 6 hours of each other in order for the patient to screen positive for sepsis. So that's something that will be less important in the ER, but on the floor you definitely want to be paying attention to that. So the start time is pretty simple in this one. It's going to be 7:30, you initial here. So you're still going to want to fill out this bottom part because you're drawing blood cultures. You need to know how long you have to draw those and then how long you have to draw your lactic acid. So if you calculate it here, you take the start time, which is 7:30, and you have 3 hours, so you have until You have until 10:30. And then the 6-hour mark would be 13:30. All right, so you want to make sure that you get your blood cultures drawn in time. So you'll end up just writing the time down here. So let's say that you drew them at 9 o'clock, and you also drew your lactic acid at 9 o'clock. All right, so let's say that our lactic acid results was 2.8. Let's go ahead and initial. Antibiotics have already been given, so the documentation on the time really isn't that important. You can probably just draw a line through that, or it'll be pretty obvious in the charting that they're already on antibiotics. So, and the patient's lactic acid isn't greater than 4, and they're not hypotensive, so more than likely they're not going to, the physician won't be ordering a 30 mils per kg. They may give him a little bit of a bolus because the lactic is greater than 2, and our goal is less than 2. So you can draw a line through that also. All right, so the reason I wanted to bring up this scenario is because one of the things that we are falling out on the most is making sure that we are first getting a lactic acid and redrawing a lactic acid. And like I mentioned earlier, lab is going to, if we're drawing an initial lactic acid, they're going to automatically order another one for us. I believe it's within 4 hours. I could be wrong. It could be within 3. I don't remember. But so that's just something that we really want to try and push when we're talking to the physician. So if they screen positive for sepsis, just making sure that we're getting at least the lactic acid. So you're not obviously going to have to do any volume resuscitation, so that one just can kind of be ignored, crossed out, whatever. And then just make sure that when you get the lactic acid result drawn that you are also writing that down and the time that it was drawn. So obviously want to make sure it's done before 13:30, so let's say that we got it done at noonish. So don't have to start any pressers. So this is a kind of a unique scenario, but one that you probably will more commonly see on the floor. So once again, just making sure that we're getting the lactic acid, because that is something that we're falling out on quite a bit. So and then again, once you're done with this tool, just make sure that you're signing your name at the bottom, initialing, and then it's not a permanent part of the record, so just return it to the ICU. And that's what I've got. Alright, so we've gone through our case studies. I just have a few other things that I wanted to mention to you guys that are just kind of some housekeeping things. So like I mentioned when I was going through the case studies, lab will automatically draw a second lactic acid. So you guys hopefully don't have to worry about that. I would still recommend communicating with them to make sure that they are getting that second lactic acid drawn. And it should, I think the standard is going to be, it will be within 4 hours, so then it automatically meets the 6-hour event criteria. One thing that I didn't know, like my first 2 years of nursing, is that typically we start the 30 mils per kg if the lactic acid is greater than 4. So it's not something that you're going to expect on every patient that screens positive for sepsis. It's typically when you have a higher lactic acid. So just some random FYI for you. Obviously, you're not always going to get these orders from the physician, so just make sure that you're documenting all of your efforts of when you're notifying the doctor what the conversation was. It is important to have documented. There are going to be reasons sometimes that we don't do what is required, so just make sure that you are documenting when you notify the physician so that we can kind of track that, and just then we'll end up reviewing the cases later to see what happened. So this new tool isn't a part of the permanent record, so when you're done with it, go ahead and I would make a copy of the sheet and then put it in the patient's folder, and then give a copy to Julia in the ICU, and I believe they're going to have a a folder in the ICU for those to go. So just bring it over to the ICU and then they'll be able to tell you where to go from there. Alright, so that is the end of this presentation. Hopefully it wasn't too bad for you. Again, I realize this is kind of a lot of information at first. It's definitely not going to be without speed bumps in the beginning. If you guys have any suggestions of how to smooth out the process or any changes that you've noticed need to be made, feel free to email either me or Julia. Or if you just have any questions in general about sepsis, the process, anything like that, I'd be very happy to answer them. So, alright, and that's all I have. Thank you guys.